It's Kevin Hardy from Hardy Group. We're at the Nepean Blue Mountains Health Conference called Together Achieving Better Health, and we're talking now with Chris Baggoley, one of the keynote speakers. Welcome, Chris.
Kevin,
good to see you.
Thank you. Yes, pleasure to be here.
Thank you so much. Look, Chris is the Chief Medical Advisor for Calvary Healthcare, and before this has been the Australian Government Chief Medical Officer and the Chief Executive of the Australian Commission on Safety and Quality. Welcome. Thank you for agreeing to talk, and let's start. What will make quality improvements sustainable long term?
Well, Kevin, I think we heard today from all speakers about it's a multiplicity of factors that make health, safety and quality sustainable. And you can boil them down to organisational factors, to patient and family factors, to staff factors, and also to regulation. I must admit, I don't mind a bit of regulation. I think it helps make a difference. And people talk about the culture of an organisation, but that might be, if you've got a respectful organisation, you've got strong leadership, you celebrate success. So it's a range of activities there. But if I was to think about what it is that moves staff, and be they doctors, nurses, board members, whatever, they all have a focus on patients, the consumers of their healthcare and their families, and they need to live that. They really need to be at the centre of what they do. That's important. And the other thing that drives clinicians in particular, but also those others I mentioned, is the provision of data, timely data, so that the doctors, those at head units, but the nurses, anything that can be measured is provided in a timely way that can make a difference. Everyone wants to do better, and if they've got the data that is fresh, that can make a difference, that will make a difference, and then that's going to help sustain quality improvement.
You've talked before about organisational turbulence, so that can be both get in the way of quality improvement, but could also be a disruptor to help advance the agenda. What are your thoughts about that?
What we know about organisations is that the setting for improvement is greatly enhanced by stability of leadership. And what we also know in our health systems, and particularly in Australia, and I do focus on, now on South Australia, which is my home state, is the continual change of chief executives of hospitals and networks who bring in fresh ideas when people are getting used to the fresh ideas of their predecessor, so that in the end the doctors and the nurses just get a sense that this change is constant, nothing is followed through, and what is constant for them is their work with patients. That's what they do, that's what they're best at. And while they might want to be part of an organisation, that organisation is so turbulent, just let those fads come and go. And there may well be someone that comes along who's really got fantastic ideas, great skills, but people have to decide how much of myself am I going to invest in this person, in this organisation. And of course, if they don't invest, that leader may not be successful and they may be moved on. So, and what executives are often judged by is the financial performance of their organisation. And if they know that improved quality care improves financial performance, but if they're not given the time and they're in a hurry to get things done, then it's going to be hard for the doctors and nurses to really join with them. And I've spoken to docs and nurses at Flinders Medical Centre where I work. We've been there for 30 years. Brilliant people, great clinicians, but what they've seen and the people they've seen come and go over the years is quite, it is disruptive.
Of course.
Turbulent times, of course, can bring up great ideas and great solutions. So it can work both ways.
Yes, yeah, no, absolutely. And you can understand why people respond the way clinicians respond the way they do, because when you see a continual rollover of chief executives and you invest in one and then they're gone, then it's sort of like, well, start again.
Yes, yes.
And quite often clinicians do want to be part of a better future for that health system.
Yeah, indeed.
Exactly.
Oh, yes. I mean, everyone wants the system to get better, and they want the system to support them as they do that.
Yes.
But if the system becomes preoccupied with organisational change, seemingly for its own sake, then you can lose people.
Yeah. You talked about finances. One of the spin-offs of good quality improvement also is improved financial performance quite often. But sometimes the quality improvement agenda is a 3-year investment or longer, well, obviously longer, whereas the financial imperatives are day by day, month by month, year by year. So there's almost an inbuilt tension to the leadership having courage. Did you have any thoughts about that?
Yes, I was just involved yesterday in a hospital, not here in New South Wales, I won't say where it is, where the head of the health department, the chief exec of the network, treasury officials and so on, they came to help to see what could happen to do something about the financial status of this hospital. And they were ushered into the operations room, and we've heard now how many hospitals and networks have similar places. And where the discussion was had about cost is made up of a range of components, and they looked at and are measuring safety. By safety, they're looking at safety of staff. They're looking at quality and quality improvement. Yeah. They're looking at delivery of care. Those things are actually happening. They're looking at the people factors, turnover and so on. Yeah. Put all those together and you have costs. And it was understood. And in fact, the head of that health department understood that if quality was improved, patient turnover, there were fewer complications was a focus, then cost will improvements will come along with it. And it was understood these things take time. This organisation has been focusing on quality for a long time. Yeah. Part of the regulation side of things is bringing a sharp focus to this, of course, is the introduction of health care acquired complications, or the HACs as people talk about them now, which the Independent Hospital Pricing Authority, or IPA, has introduced now as part of the financial mix. So when money gets married with quality improvement, then I think it can be a great incentive. It's got to be handled carefully, but it means that everyone then has a focus on quality and focusing on those issues that prolong patient stay or cause complications, and for varying reasons and from varying perspectives, can only improve patient care, I think.
Yeah, thank you. You've mentioned that the health system is like a bird.
Yes.
What do you mean by that?
Yes. Well, this is, and I don't take credit for this, but boy, it stuck with me. I remember a presentation from Geoffrey Braithwaite, and the slide he had, which he's let me use, where he talked about people's attitudes to the health system and affecting change. And he said there are a group of people, often can be regulators, health department folk, even ministers, who've got a sense, if only we did this, the outcome will be predictable. So it's like holding a rock in your hand. If you throw a rock, you know where it's going to land. Sure. You've got some basic physics. Yeah. And this idea, launched into the air, will produce a definite result. Whereas those who work in the health system, they know that making change, affecting change, isn't easy. It's complicated. It needs constant attention. And Geoffrey, and maybe he got it from others, likens it to holding a bird in your hand. Yes, yes. And if you want, and change and the system is like a bird. Birds have to be nurtured, they have to be cared for, but they've got minds of their own. So you throw a bird in the air, and you watch where it goes, make sure it's fed, but you can't be sure where it's going to land. It may come straight back home to roost. It might be one of those sort of birds. And you may not get far at all, but you've got to persist. And its change and affecting change is not as predictable as people would like to think.
Yep. You've talked before about health literacy.
Yes.
Would you like to say a little bit more about that?
Yes, I think the understanding that the patients and the consumers of healthcare may not understand what it is the health professionals are saying to them or advising them hasn't been well understood. And what really made a difference for me in this was a study, I think a brilliant study conducted by the Australian Bureau of Statistics, published back in 2008, where they looked at 27,000 people. So they spoke to them, they gave them 5 pieces of information and asked them to interpret it. It could have been directions for their next appointment with a doctor. It could be an article written in a popular magazine.
Sure.
Those sort of things. What they found was that 2/3 of patients did not have the basic health literacy that was needed to even deal with those matters. Worse, it was the older the people were, and probably for a variety of reasons, the less they understood. And also the sicker people were, the less they understood. So, it's skewed in all the wrong ways, which is why the health system needs to accept that, try and do something about it, but work with it, so that they know that the patient or their carers, both, when they're given information, when they're given advice, given in a way that they understand, check that they do understand it, and constantly focus on that, because what we also know is that patient-centred healthcare is the best way to get the best results. But you can't have patient-centred care if the patient doesn't get it.
Doesn't get it, yes. Okay. Chris, I thank you so much for your time. It has been an absolute pleasure talking to you. I really appreciate it.
Kevin, thank you. It's been great to be here.
Thank you.